Hi, this is part of the recording for the GI conditions. I'm going to start with hepatitis. I know we're going to cover a lot of stuff in class, but I just wanted to add in case when we get to these conditions, we are probably moving a little bit, faster than so that you will have something to listen to or refer to when you are studying. Again, it's possible, I've used this before. The chapter may be a little bit off, but I think it's chapter 61. So anything was starting with hepatitis, just as you know, anything that is an TIS is an inflammation. So hepatitis is an inflammation of the liver. There are various causes of hepatitis. You have a lot of, hepatitis due to viruses. It's a wide range of even the viruses themselves. Even as we speak, they are coming up with newer viruses. Can be due to drugs. I'm sure you know, for example, things like Tylenol. There's a warning, on the Tylenol as to, how much people can take in a given day. And of course, alcohol, particularly where there is abuse of alcohol. The range of hepatitis can vary from being mild to life-threatening, where if it's life-threatening, there's, a sudden deterioration as far as, functions of the liver, and death can occur within a few, within a few months. Pathophysiology, again, you're never going to get questions that will ask you about patho, but it helps you in terms of understanding the disease process. It's going to vary, again, depending on the cause, but basically, a lot is going to depend how much of the liver has been damaged, as well as the client's concurrent health status. For example, if you take, somebody who is an alcoholic, and they end up with hepatitis, they may be malnourished because they are not eating well, or somebody who probably is sick and maybe they are ill and they get a drug that causes liver damage. Is going to be different in terms of their response. Okay, the first type that we're going to look at is alcoholic hepatitis, and that is due to chronic alcohol abuse or acute toxic reaction to alcohol. The main thing, once it's alcoholic, obviously treatment is to avoid alcohol and to support liver function. Much as the liver cells cannot regenerate, but it does, if an individual who is an alcoholic and they've developed probably on the early stages of hepatitis, they stop drinking, they have a better prognosis than somebody who continues to drink. Toxic hepatitis, this can be due to different drugs. For example, number one, acetaminophen. We know that Tylenol, you even get, when you are giving out the medication, it will pop out to say, has the patient exceeded, 4 grams. Benzene, carbon tetrachloride, halothane. Some of these are gases or, chemicals that are used in industry for cleaning, etc., etc. Same with chloroform. You don't, if you remember in the good old days, chloroform used to be used as an anesthetic, but not anymore. Then hepatobiliary, obviously, if it's hepatobiliary, there's a connection between the liver and the gallbladder and the biliary tree. So this hepatitis develops because of interruption due to the normal flow of bile. Can be due to obstruction of the hepatic duct or the gallbladder, the ducts, that carry bile from the gallbladder to the liver. Could be an obstruction due to a gallstone over time. Okay? It's not everybody that has gallstones that end up with hepatitis. Viral hepatitis, infectious disease that attacks the liver, obviously caused by a virus. There are so many types of viruses. I think if you look at that, it looks like we're five, but I think they've actually been identified up to eight. Types A, B, and C are the most common, as well as types D and E. Okay, and like I say, they are, you know, almost on a daily basis they're coming up with newer ones. Okay. We'll start off with probably really our focus is mostly going to be on type A, B, and C. Okay, type A. Once you see type A, it's infectious, and the primary source is due to contamination, you know, with human feces. So if it's human feces, its transmission is through the oral fecal route, right? It's spread by oral intake of either food, milk, or water that is contaminated. Hepatitis A says it's the most common form today. It has a carrier stage. It's possible for somebody who has hepatitis, they might recover and are not completely, they become a carrier of the disease. The virus is not completely eliminated from their system. And if there's contamination, let's say if they contaminate they contaminate water or food, other people can become infected that way, which is why, as far as food handlers, they normally will check to see if somebody is a carrier on a periodic basis, because you'll hear, particularly in the food industry, restaurants may be eating even vegetables that are contaminated, salads that are contaminated, etc., etc. Then type B, that's your body and blood and body fluids. Right? Again, just to probably to help you remember type B, blood. Okay, that also referred to as serum hepatitis. The other one we said is referred to as infectious hepatitis. Right, so serum is going to be in the blood, it's going to be in the body fluids. It is spread by sexual contact. It's spread in the blood products, needle sticks, sharing of needles. Again, with the blood products, probably it has become better, but where, maybe 30, 40 years ago, blood transfusion, people that were involved, they say they were in a massive, probably, motor vehicle accident and maybe received 10, 20 units of whole blood, and they probably didn't check for the virus. It is possible to get hepatitis in that manner. Needle sticks, that is why, if you're in a for health setting, we always tell you, no recapping of needles. That's why there's so much in terms of safety, about needles, so that healthcare personnel do not stick themselves unnecessarily. Okay. We also know it can be transmitted through breast milk, since that's a body fluid, for those women that are breastfeeding. Type C is also related to blood, and mostly due to transfusion related. It's referred to as viral hepatitis. Again, more common in IV drug users, as well as personnel working areas where there's high blood contact. For example, dialysis units, in the operating room, etc. It's a more severe form of hepatitis, can lead to cirrhosis of the liver and liver failure. Type D is transmitted by blood and sexual contact. It's usually co-infection of hepatitis B. Type E route is fecal oral. It's more in underdeveloped countries. Okay. Again, the main ones, like I said, A, B, C. A, we said, was infectious hepatitis, fecal oral route. B, blood, body fluids. C, still blood, mostly through blood transfusion. as well as anything where there's high levels of blood. Okay, so there's in C, so it is the most virulent form. Okay, right. Signs and symptoms. Oops. Can occur in 3 stages, which are referred to as prodromal. Prodromal, you see it in any infectious disease. Basically means really before the symptoms appear, and or also referred to as pre-icteric. Basically, icteric means they've now become jaundice or pre-jaundiced, and then icteric stage, that's when they're jaundiced. Post-icteric, that is the convalescent stage. And during the convalescent stage, patients need to be resting, because if they don't rest and they continue, particularly in terms of drugs, in terms of substances that are excreted in the liver, the situation can deteriorate, right? Or that can make the prognosis worse. Okay, so icteric basically means they've jaundice, right? And it's easy really to avoid, if you're thinking about people that share needles. If somebody looks jaundice, nobody's going to share a needle with them. But the danger comes when during that prodromal or during that pre-icteric stage. Right, prodromal or pre-icteric lasts about a week. They present with flu-like symptoms such as malaise, headache, anorexia. They may have a low-grade fever, dull right upper quadrant pain because of the location of the liver. And then the icteric may last anywhere from 4 to 6 weeks. They have severe fatigue, they are tired, anorexia, nausea, vomiting, all these have to do with the GI. And then, of course, they become jaundiced due to elevated bilirubin, because the liver is not able to work, on the bile to change it to where it can be excreted, so it, goes back into the blood. Okay. And the urine presents as dark amber urine because of the high levels of bilirubin, and the stool is described as clay-colored stool. Due to accumulation of bile salts on the skin, they'll have pruritus and irritating, scratching, itching, and so on. At this time, the liver is usually enlarged and tender. And then post-icteric, this is after, again may last from 2 to 4 weeks up to several months. They may feel well, but liver function may not return full liver function may not return up to a year. Okay, obviously during this time they have to avoid anything that is going to irritate the liver, such as alcohol or even drugs. Okay, these need to be avoided to allow the liver an opportunity to heal. And then talk of as far as recovery, because majority of of these, when we talk about hepatitis, all we talked about as far as causes were viruses. So there is no specific treatment for viral hepatitis, although of lately I've been seeing a drug on the television for hepatitis C. So obviously there is a lot of research that is going on, and there probably are some newer drugs that we may not be aware of at this time. But the main thing, particularly if it's a straightforward things like hepatitis A, they usually if they comply with adequate rest, good nutrition, no drugs, no alcohol, they do have a good prognosis. Okay. Complications that may follow: hepatitis, it may lead to acute liver failure. They can also develop chronic liver failure, and then even with hepatitis B, they may develop liver cancer. Okay, so it is, particularly in Africa, actually did take care of some people that had hepatitis B who developed liver cancer. Diagnostic tests include liver enzymes, which are elevated, and these are, AST and ALT. Most of the time, these have long names. You will just see them as serum liver enzymes, right? So if you have a patient who has liver disease, usually what a physician, they'll order serum liver enzymes. They are not going to say AST or ALT or whatever. And then the other thing, elevated erythrocyte sedimentation rate, it's non-specific. And elevated ESR occurs in any infectious process or in any inflammatory process. In severe cases, prothrombin time may be, elevated. If you remember, the liver, plays a part as far as prothrombin is concerned. You have to again to go back and look at the, those functions of the liver. Okay. And then there are specific serum tests for each type of virus. Treatment, main thing is rest and adequate nutrition in order to support healing. Again, there's no specific treatment. The main thing is restriction of drugs that need to be metabolized by the liver. Alcohol obviously needs to be avoided. Okay. And then the other type of liver failure or acute liver failure is also referred to as fulminant liver failure. So this one occurs very suddenly, rapidly, and it's usually fatal. It causes hepatic encephalopathy. Central nervous system dysfunction occurs in several weeks. You'll remember again that the liver, together with the kidneys, play a part as far as metabolizing urea. So if the liver is not functioning adequately, levels of urea, levels of ammonia are going to increase in the blood. And when they do, they're going to go to the brain and they become toxic to the brain. Once the ammonia, urea is in the brain, it will cause things like seizures because it's not supposed to be there. Okay. Pathology for acute or for the fulminant liver failure, anything that's going to cause sudden massive loss of liver tissue or necrosis. Could be due to drug toxicity, could be due to a virus. Again, just give an example of somebody who may have taken maybe accidentally or intentionally an overdose of Tylenol. They may find themselves in that situation. Okay. Outcomes, it's possible. Reversal is, it's a possibility, but most of the time they do require a liver transplant. Okay, nowadays these are available, and the liver is such an exceptional organ. They don't necessarily have to have the whole liver. Sometimes just having that, whether it's a partial transplant, it seems to work. Okay, and those, they are done. Okay, even here in, I think UAB probably does those. Okay. Signs and symptoms of that acute fulminant liver failure: sudden lapse into extremely serious illness in a few hours. They may end up with confusion, progressing into coma because of the high levels of ammonia, and the liver becomes small in a few hours. Okay. Whereas with the other, when we talk about hepatitis, we said it was inflamed, it was tender, it was swollen, but this time it shrinks real quickly. The amount of destruction to the liver cells occurs very rapidly. and there's sudden elevation of liver enzymes, bilirubin, and protein. Okay. And then the liver test. Oops, let me go back. Right. Earlier on, I talked about the serum liver enzymes, but here I'm just trying to define what they are. But again, like I said, I would not sit there and try and memorize them. As long as if you're looking at, you see ALT, you see AST, you kind of have to remember that's the liver enzyme test. Okay. And ALT stands for alanine aminotransferase, and AST stands for aspartate aminotransferase. And you know, like I said, those full names are nice to know. Things like the serum potassium drops, blood sugar also drops as well, because the liver is not able to release what it stores, you know, as glycogen because of the damage. Main thing with treatment, the liver should be put completely at rest. No drugs. The patient themselves should be at rest. Anyway, they are too ill for anything else. Okay? If it's due to an overdose of drugs, then they would require dialysis. Diet-wise, they require high calorie, low sodium, low protein diet. Okay? Low sodium, because sometimes they may have fluid retention as well. Low protein, because again, you know, just like we were talking about in the renal conditions, the end product of protein digestion is going to be urea, ammonia. So these need to be eliminated from the diet. And other drugs that can be used, mostly these are given to decrease ammonium levels, lactulose, neomycin, magnesium citrate, or sorbitol. Lactulose, sorbitol, they are sweet. Okay, I think they are sweet, but basically what they do, they're going to cause diarrhea, and that causes excretion of ammonia with the stool. Where, you know, like we said, there are some patients that may have chronic liver failure. You may find that they are on lactulose maybe twice a day, lactulose 3 times a day. Right? And at times they might complain and say, well, you know, I'm having diarrhea, I don't need this. But most of the time they do need their lactulose, because that's, you know, just that is how it's going to get rid of the ammonia. If they don't take their medication, the ammonia levels are going to rise in the blood, and they'll start getting confused. Neomycin combines, it gets, you know, the ammonia can come from protein digestion. It also comes from the lower GI, where there's, you know, with the microorganisms, you know, as they are combined, you know, as they are in the GI, they also produce ammonia. So neomycin gets rid of the microorganisms. Okay, complications of acute liver failure, things like metabolic alkalosis, hypokalemia, hypoglycemia, altered blood clotting, sepsis, because if you remember, we talked about the fact that, you know, they are on a protein diet. Systemically, they are so, you know, ill. Their resistance is decreased, so they will pick up any infection very easily. Okay, chronic liver failure. So that was acute. Chronic liver failure, you may see it referred to either as Lennox cirrhosis, portal, nutritional, or alcoholic liver disease. Okay. Main cause for, you know, chronic liver disease or cirrhosis is excessive alcohol ingestion with poor dietary proteins. Because sometimes what happens when people are drinking, they don't have time to eat. They feel full, they don't eat. okay, or they don't eat well, or they may, just eat the wrong type of food. Okay. A massive exposure to anything that is toxic to the liver, whether I talk about viral hepatitis, biliary liver failure due to gallbladder disease, like we said earlier on, any gallstones, anything that is going to obstruct the flow of bile in and out of the liver may cause cirrhosis. And in the long run, because once the liver fails, there tends to be fluid retention, can lead to cardiac failure. Okay. Pathophysiology: liver cells respond to toxins with inflammation. The cells become infiltrated with fat, white blood cells, then they are replaced by fibrotic tissue. So once the structure of the cells changed, it means the liver can no longer perform its functions. It becomes hardened, lumpy, it's enlarged initially, and then later on it's going to shrink in size because of scar tissue. Okay? But otherwise, the liver cells, once they change in their structure, it means their function is going to be affected or is going to be decreased. Signs and symptoms of liver disease: malaise, anorexia, indigestion, nausea, weight loss, diarrhea or constipation. They may also complain of a dull, aching right upper quadrant pain. They may have problems with bruising, bleeding, anemia, jaundice, again that dry, itchy skin, the pruritus, because of the accumulation of bile salts under the skin. So you can see really right at the beginning, if you are talking about hepatitis, cirrhosis, liver failure, there are kind of certain similarities as far as generalized, nothing specific, but most of them focus on the GI. They focus on the inability of the liver to perform its functions. Okay, complications of cirrhosis of the liver. We talk about hepatorenal syndrome because of the communication between, or in terms of the function between the liver and the kidneys. Blood clotting defects, because there's a reduction, in the formation of the clotting components. Ascites, the plasma proteins are decreased, and instead of fluid being retained inside the cell, it escapes and is causing the ascites. Portal hypertension, it means as the blood flow is coming in from the GI, there is no, because of the change in the structure of the liver, it's not able to circulate freely, and the pressure increases, causing the portal hypertension. And then, of course, the last thing, hepatic encephalopathy, with the brain being affected because of the high levels of urea. Right, continuing with the complications, hepatorenal syndrome basically means there's oliguria without detectable kidney damage. There's a reduced glomerular filtration rate. Urine can be between 0 and 200 cc's. Total sodium retention, it's not a good, it's a bad sign. Basically what we're saying, the kidneys are failing, probably because of those high levels of urea. And then the blood clotting defects occur due to impaired prothrombin and fibrinogen production, malabsorption of vitamin K. You can end up with bruising. DIC, I'm sure you remember DIC from maternal and child. This is disseminated intravascular coagulation. where they may end up with bleeding from any area, from the GI, from the nose, from the renal. Right. And then ascites. This is accumulation of serous fluid in the abdominal cavity, and is due to low albumin, which is part of the plasma proteins which are produced in the liver, and this it allows fluid to escape through the capillaries, causing what we're referring to as a capillary leak. It causes an enlarged abdomen and difficulty in breathing. A patient that has ascites needs to be weighed daily, and they need to have their abdominal girth measured. You have to have a tape measure and measure the size of the abdomen. And then portal hypertension, persistent blood pressure elevation in the portal circulation of the abdomen, and they end up with distended veins around the umbilicus. And with that hypertension, they also end up with hemorrhoids and esophageal varices. Esophageal varices occur from the fundus of the stomach upward into the esophagus. These are thin veins. Okay, the veins, because of the pressure, become thin, they rupture easily, they bleed easily. And then hepatitis, I'm not sure about that. I guess I did say hepatic encephalopathy, due to accumulation of noxious substance in circulation, mainly due to high levels of protein. Anytime that you see encephalopathy, protein, you should expect that the diet is going to be reduced in protein because of the risk. And then ammonia is also the main toxin causing progressive confusion, asterexis, which is flapping tremors of the hand due to toxins at the peripheral nerves. They end up with fetal hepaticus, which is a foul breath because of ammonia. Let's see. Okay. Hepatic encephalopathy has 3 stages. Nice to know. Okay, I won't go sit there memorizing. Main ones are early subtle changes in personality, fatigue, drowsiness, changes in the handwriting, and then eventually, if nothing is done, then they become more confused, hostile, irritable, and they develop that asterexis, muscle twitching, and marked confusion. So it's very important to, again, like I always say, your main role for most of these, not so much for you to memorize, some of these stages, but be aware in terms of assessing your patient. Right? If your patient was fine, they have a history of liver disease, now they are confused, now they are sleeping and you cannot wake them up, that should be a cause of concern versus you knowing what stage they're at. I hope I make myself clear. And then obviously they go into a coma stage, okay, and they lose consciousness and they become comatose. Main thing, again, just to go back on much as I've gotten these stages, you don't have a patient that goes from they are alert, now they are in a coma. Okay, they are usually those warning signs. This is where you need to focus, right? To say to yourself, why is my patient irritable? Why are they drowsy? Why are they sleeping so much? And note those changes and alert your healthcare provider. Okay, just like I said, in most cases, you will, in long-term care, come across patients who have chronic liver failure, and with that chronic liver failure, they might be on medication, they might be on lactulose. So you want to make sure you are giving that lactulose. Sometimes the patient may become reluctant because they might say, well, I'm so tired of, having diarrhea or going to the bathroom. You still have to explain that is how the medicine is working to get rid of the toxins in their body or in their bloodstream. Okay, you have to think about ascites, use of diuretics, which you already know. But they can also get infusions of albumin. They also need to go on sodium restriction, right? Anytime that you have ascites, fluid is being retained, sodium needs to be restricted. They might do a paracentesis where they put a nickel and remove the fluid. Okay, unfortunately, if it's really, if it's due to chronic, liver failure, if it's due to liver cirrhosis, most of the time the fluid will, reaccumulate, because the problem really has not been solved. Okay, until they get that liver transplant, that's when they actually probably will be free of the ascites. And they may also create a shunt. Okay, nice to know. Okay. And then with the varices, so here I'm looking at the complications, how the complications are treated. With the varices, we say they are, they are inflamed, they are swollen. They can inject what is known as sclerosing agent, which makes them harder, okay, and reduces the inflammation. They may ligate them, and they may, if they are bleeding actively, that is an emergency. Okay, they can insert a balloon, which is, they can insert a tube, okay, through the nose into the esophagus, and it has balloons. It's going to apply pressure on the bleeding vessels in the esophagus as well as in the stomach. It's known as a esophageal gastric balloon. Okay, it goes by different names. Okay, so that was all on the liver. The next thing that we're looking at is the pancreas, or pancreatitis, and that's an inflammation of the pancreas. Again, varies, mild, severe, acute, or chronic. Two major factors associated with the development of pancreatitis: alcohol as well as biliary tract disease. It's possible a patient that has, let's say if they have hepatitis, if they have liver cirrhosis due to alcohol, they may also end up with pancreatitis because the cause is going to be the same. And just like, maybe just to emphasize, it is possible for people that never drank to have liver cirrhosis as well as pancreatitis, mostly because it can be related to gallbladder disease as well. But what we're saying, majority of the people that develop cirrhosis of the liver, that develop pancreatitis, is usually due to drinking alcohol. Okay. Again, can have acute and chronic. Okay. Acute pancreatitis is an inflammation. It's usually painful and it's due to autodigestion. Okay. What happens is the pancreatic enzymes are activated within the pancreas and they begin to digest the pancreas because it's a protein. If you remember, those enzymes, the pancreatic enzymes, deal with protein digestion. So if for some unknown reason they are released within the pancreas itself, they can start breaking it down. Most of the time when they are produced by the, they're carried via the the pancreatic duct to the duodenum, to where they're going to aid with the digestion of protein. But this time they start breaking down the pancreas within itself. Okay, so in addition, there's vasodilation, capillary permeability, and fluid is going to be lost into the rectal peritoneal space, again causing things like ascites, that inflammation, and it's going to cause, if you have fluid that is removed from the intracellular, is going to lead to hypotension and so. Those are the three causes. Again, alcohol is at the top. gallstones and trauma to the abdomen, infection. Signs and symptoms: severe abdominal pain radiating to the back, and sometimes they might report relief if they lean forward while they're sitting. The abdomen is rigid on palpation. They may develop jaundice if the bile duct is obstructed. Then hypotension, shock, respiratory distress, because of the pain, they are not going to be able to breathe fully. They are going to hold themselves rigid because breathing in and out hurts. Then hypotension, because they've lost some of that fluid, is now in the tissues. May run a low-grade fever, tachycardia, nausea and vomiting. Okay. The nausea and vomiting can be quite severe, to where they require a nasogastric tube. Okay. Signs and symptoms: key diagnostic lab work is an elevation of the pancreatic enzymes, and an example would be your amylase and your lipase, and these are going to be checked periodically. As the patient recovers, they should also decrease. Okay. Treatment depends on the severity of the attack. Sometimes they, severe, there may be maintenance of life support until the inflammation resolves. Okay, but the key word, if it's just a straightforward acute pancreatitis, the patient is going to be NPO, and because if they eat, that's going to stimulate the pancreas to work and cause more pain. Okay, so they're usually NPO. They usually have a nasogastric tube for decompression to remove any fluid from the GI. They will, anytime that you see a patient that is NPO, they're nauseated, they are vomiting, they have a nasogastric tube, they always will have IV fluids. Okay. Oxygen therapy, because they say they may be afraid to breathe deeply. They may require anti-anxiety drugs. They require pain medication, intravenously, usually by IV push, versus their own oral pain medication is not going to work on these patients. They require everything to be given IV. And your other drugs, your histamine antagonist, I have Zantac there, but we know you have newer ones, things like Protonix and so on. And they may need TPN, worst case scenario. Treatment, they may require sodium bicarb if there's acidosis, replacement of electrolytes, regular insulin, hyperglycemia. They obviously are going to need to have their blood sugars checked, because if the pancreas is not functioning properly, it's not going to produce adequate insulin, and the blood sugar is going to rise. That's why they need to go on insulin. Antibiotics, mostly for prophylactic reasons, to prevent sepsis, because remember I said the fluid can escape into the peritoneal cavity, and once it's in the peritoneal cavity, it's going to cause inflammation, and the risk of infection increases. Okay. Chronic pancreatitis may follow acute. Again, just to go back, those patients that end up with, let's say again, we're going to use the paper that abuse alcohol. If they continue to abuse alcohol, they have several, attacks of acute pancreatitis. At some point, they can go into a chronic pancreatitis. So if it is chronic, it means the structure of the pancreatic tissue is going to change. It's going to be replaced by fibrotic tissue. If it's replaced by fibrotic tissue, it means the function of the pancreas is now going to be affected. Okay, and pain-wise, they do have pain, but it's less severe. They may go through periods where they have periods of remission, periods of exacerbation, complaining of right upper quadrant pain, weight loss, anorexia, may have malabsorption issues, fat intolerance because of the enzymes. Eventually, they may end up with diabetes because production of insulin is also affected. And complications may include abscess of fistulas because of that inflammatory process, malabsorption issues, diabetes mellitus. They may end up with abscesses in the abdominal cavity. Okay. Treatment is mostly promoting comfort. Once really the pancreas is chronic, again, it's one of those where possible they may, I think they do have some where they're doing transplants, but I think it's in the early stages. So they basically have to replace the pancreatic enzymes. They may have to be on insulin. They are going to require nutrition, which is well balanced, and tying it in with the enzymes and so on, okay, to minimize malabsorption. They may need specialized nutritional supplements. Cholecystitis, cholelithiasis. Now we're getting into the gallbladder. Okay. Oops. Inflammation. Cholecystitis basically is inflammation. Cholelithiasis is gallstones. If you remember when we talk about the kidneys, we talked about urolithiasis, so it's kind of the same word. Okay. When we're looking at probably the liver, the hepatitis, pancreatitis, cholecystitis is more common than any of those. Okay. And just the diagram there of the liver and the gallbladder. Inflammation is cholecystitis, and is due to obstruction of the common bile duct. 90% of cases are due to gallstones. Bacteria may invade the bile and cause an inflammation, and then chronic is usually due to repeated attacks of acute. Okay, and over time with chronic, gallbladder becomes fibrotic, thickened, and doesn't empty well. If it doesn't empty well, it means the bile is not getting to the liver. It's going to have an effect on the functions of the liver, as well as breaking down of fats, etc., etc. Cholelithiasis, gallstones. Again, there are different types of stones. Excuse me. Most of them right, so gallstones can block the common bile duct, and risk factors to gallstones, that's what they are. It's got nothing to do with me. Fair complexion, fat, female, 40, and fatal. Those are the risk factors. Signs and symptoms to cholelithiasis: fever, rapid pulse, respirations, vomiting, nausea, anorexia, flatulence due to poor fat digestion, jaundice due to blockage, right upper quadrant pain, keyword, radius behind the right scapula or shoulder, particularly after a fatty meal because of, that's the referred pain. When pain is made worse on breathing, so obviously they are going to try and not breathe. They may end up with diaphoresis because of the severity of the pain. Stools are clear colored because there's no bile getting through. Urine described as amber colored, tea colored. Complications include inflammation of the bile ducts, necrosis, or perforation of the gallbladder. You hear sometimes that it becomes an emergency once it perforates because it's going to spill its content into the peritoneum, causing inflammation, causing risk of infection. Can also cause acute treatment of acute pain control with opiates and antispasmodic to, because just like when we're talking about kidney stones, once there's an obstruction, the bile ducts are going to try and increase peristalsis to push the stone through. Demerol is the drug of choice for pain. And diet should be high protein and low fat diet. Okay. Stones treated, removed, surgical removal, whether they're done laparoscopically or traditionally. The procedure is a cystectomy, and they have a special drainage that is known as a T-tube, which drains it. Once the gallbladder is removed, once the gallbladder is removed, it's going to direct the bile straight from the liver to the duodenum. They can still do that lithotripsy. Like we say, they do shock wave to break the stone down into smaller pieces. Okay. And those are some of the dietary concerns for hepatitis. Okay, so like I said, I am recording part of this, otherwise the rest we're going to cover in class.